Suicide is more than a public health problem. It's a public health and social problem. The book by John Bateson that has come out in September of 2024, Suicide, Understanding and Ending in National Tragedy. This is the book we are going to talk about today on the Intentional Clinician podcast with Paul Krauss. John's book examines myths, demographics, risk factors, warning signs, and how to talk to a suicidal person. It covers suicide in parks, prisons, and in the military, as well as assisted suicide, suicide by cop, and murder-suicide. More importantly, it details the relationships between guns and suicide, drugs and suicide, and jump sites and suicide, focusing on one of the most effective ways to prevent suicide, restricting access to lethal means. The last chapter describes important steps that individuals, businesses, and government can take to end suicides. John Bateson was the executive director of a nationally certified crisis intervention and suicide prevention center in San Francisco Bay Area for 16 years. He has been the executive director of 3 university counseling centers and the deputy director of a multi-county social service agency. He was on the steering committee of the National Suicide Prevention Lifeline, now known as 988, the Suicide and Crisis Lifeline, and was appointed to a blue ribbon committee that created the, quote, California Strategic Plan on Suicide Prevention, unquote. John Bateson has been featured as a presenter at conferences such as the National Association of Crisis Center Directors and the American Association of Suicidology. And he has received a special commendation from the California legislature and was chosen to carry the Olympic torch. My name is Paul Krauss. You're listening to the Intentional Clinician podcast, and I hope you enjoy this interview. Thank you for coming onto the podcast, John Bateson. So great to have you here.
Thanks for inviting me, Paul.
Absolutely. It's my pleasure. And I have been reading your new book titled Suicide, which is quite a dark topic for a lot of folks, a topic to be avoided. But I will say, so far in reading it, I have learned a lot. And I've been a clinician for 18 years now. So I learned a lot that I didn't know. And I have to say, unlike a lot of academic sort of books, this is a page turner. So I think you definitely wrote this for the average person. So I was able to read it quite quickly. So thank you.
Well, you're welcome. That was the intention. I'm not a clinician, as I mentioned in the book. I have supervised clinicians in the course of directing a 24-hour crisis center. But I really wanted the book directed toward the lay public to kind of introduce them to the topic of suicide, which they may have historically shied away from because it is dark, and also let them know that there's hope around the corner if people follow a number of different steps to get to a point of ending suicide.
Yes, and that is actually one of the premises of the book, which is if each segment of different societal groups and programs do certain things that you recommend, which we'll get to towards the end, you want to bring that number down to basically zero.
Right. I mean, the whole goal is to end suicide. And I mean, we may not end them entirely, but we want to get them down close enough so that it's no longer a major problem, a major public health problem in particular. I think there are basically 3 takeaways that I'd like people to find with this book. The first is that suicide is more than a mental health problem. It's a public health problem with large-scale social consequences. The second thing is that one of the most effective ways to prevent suicide is to restrict access to lethal means. So making guns safe, making drugs safe, making jump sites safe, that's a lot of it. And then the last part is to really emphasize that it is possible to effectively end suicide, and every sector of society has a role to play in that regard.
Yeah, that totally makes sense. I was reading here, and I can't remember where you put it, but you were comparing the rates of suicide in the U.S. to other tragedies that had happened, to kind of give us context.
Yes. I mean, first of all, many people don't realize that there are more than twice as many suicides in the United States as there are homicides.
Yes.
Because homicides dominate our news, they dominate our TV shows, they dominate our movies, and suicides apparently seem much less prevalent when in fact it's reverse, more than twice as many suicides. And the way to really put that in context, which I try to do in the book, is to indicate that it's equivalent to 9/11 happening every 2 weeks. And it's also equivalent to a fully loaded airplane crashing every other day. I mean, if that was to happen, everybody would be up in arms immediately over it. And yet that's the loss of life we're experiencing in this country by virtue of all the suicides that are taking place.
Yes, in fact, you said in 2022, there was a record of 49,449 suicides in the United States, and the rate among men is 23 per 100,000, 4 times as high as the rate of women, which is 6 per 400,000, according to the CDC. And for every person who died in 2021, there was 8 suicide-related hospitalizations, meaning they did not complete it, and 27 suicide attempts. And firearms were used in more than half of all suicides. So those are some very sobering statistics.
They are sobering statistics, and when you start breaking them down even further, you find that, I mean, first of all, while men are 3 or 4 times more likely to die by suicide than women actually make 3 to 4 times more attempts than men do. And the reason for the disparity is because men largely resort to a firearm. Women tend to use a drug, an overdose, and you've got a much better chance of saving someone who overdoses than you have saving them if they shot themselves. So that's one of the misnomers about suicide, is that it's not just affecting men, even though men are the ones who die most often. Women are also affected. And when we start talking about individual groups regarding suicide, you get into further fascinating, or what I find fascinating information, which is among adolescents, the way young girls and young boys respond to the suicide of a peer is very different. Typically, if a boy dies by suicide or attempts suicide, survives, and other people know about it, oftentimes his peers consider him a loser. He's such a loser he couldn't even kill himself, and he experiences diminished self-esteem. Whereas with young girls, it's quite the opposite. If a girl overdoses and survives, oftentimes her peers look at her and say, wow, she was so desperate, she tried to kill herself, and there almost becomes a sense of awe and increased status for that person. So there are a lot of challenges around understanding suicide, which is why when the media talks about it in more or less simplistic terms and trying to give you 1 or 2 reasons why someone might kill themselves, people need to understand it's quite complex behavior, and there's generally no 1, 2, or even 3 particular reasons why someone chooses to kill themselves. It's a multitude of factors that all come to the forefront at one time, kind of like a perfect storm in a person's life.
Yes, and I want to get into, I think a lot of people who listen to this who maybe even have lost people to suicide. It's often, why did they do it? But before we do that, I think that'll be the next question. I would like to give the audience a little bit of background about yourself and how you became interested in learning about suicide and trying to prevent suicide, and have written a series of books leading up to this one, including The Final Leap and several others. Would you be okay just kind of telling us a little bit about your background and how you got here?
Absolutely. So until 1996, when I became executive director of a nationally certified 24-hour suicide prevention center, I had very little background or knowledge of suicide, which might sound ironic, but that's a fact. I didn't approach the field as a clinician. But I did approach it from a point of particular interest, not because anyone close to me had died or because I had never personally attempted, but because I had read Emil Durkheim's book, Suicide, in college, and that always fascinated me. So in '96, I was hired to be executive director of a crisis center, and was really introduced to the subject of suicide. And in particular, my kind of epiphany of sorts occurred my second or third day on the job, when we had a local artists guild that went around and they put up on the walls all sorts of new paintings that the members of the Artists Guild had done. And as soon as they left, the staff went around and removed any painting that had any representation of the Golden Gate Bridge. And I didn't understand that. And I said, why? And they said, because many of the people in our grief counseling program have lost loved ones to the bridge, and seeing it depicted in a painting is very painful to them. And I had grown up in the Bay Area. I had lived in the shadow of the Golden Gate Bridge all my life. I knew that people jumped from the bridge. I had no idea the frequency of it, or much less the fact that it was the #1 suicide site in the world. But I suddenly had my eyes open to the challenges of suicide. So my first book was all about what it's like to direct a 24-hour call center, which is very different from most other nonprofit or 9-to-5 type jobs, because you're oftentimes supervising people who aren't there at the same hours that you're there. And you're trying to build continuity and teamwork among a group of people who work multiple different shifts. So that was interesting. Then once I left the crisis center, the first book I wrote was all about Golden Gate Bridge suicides. It was called The Final Leap. And shortly thereafter, I started working on a book about military suicides, because my last years at the crisis center, we had an increasing number of calls from people and families and service members who were suicidal or worried about someone who was suicidal. And I was looking around for more information about military suicides, and I couldn't find it. So I delved into the project quite seriously, and ended up writing a whole book about the history of military suicides from the Civil War to the present. And then after that, I ended up writing a book about the life of a coroner, and how coroners look at suicides, which is very different from the way they look at most other deaths. Coroners are really overwhelmed oftentimes with having to especially operate under a lot of pressures to perform autopsies and the like, and release the information to the public. And they don't often give the same attention to suicides, in that it's hard for them to feel compassion for someone who ends their life prematurely, when most of the people that they're dealing with do not have that same motivation. So then I wrote the coroner book, and then this last book, I decided that I had dealt with suicide in a number of different kind of specialized ways, and now I wanted to look at the whole subject from a broader perspective. I really wanted to tackle it from the point of view of it being a public health problem, as I said, and to suggest strategies that, if they were implemented, would go a long way towards ending the problem. So even though I don't have a clinical background per se, I've been in the field a long time, and it's enabled me to look at the subject of suicide perhaps in a way that's a little bit different than the way a clinician might look at it. One of the things I discovered at the crisis center, which I found quite interesting, but also surprising, was that a number of physicians and clinicians actually called our crisis lines because they had a suicidal patient and they didn't know how to deal with that person. And you find that when you've got staff and volunteers who answer a suicide hotline 24/7, they end up having a lot more experience listening to and talking to suicidal people than the average professional. And this disparity is further heightened by the fact that most physicians and therapists do not have to have any suicide prevention training to attain or retain licenses. It's an option, and they can certainly take it. But unlike domestic violence or child abuse or elder abuse, which are mandates, suicide prevention is not. And so many professionals do not have the same level of training around suicide prevention that volunteers on a suicide hotline have. Another thing is that volunteers on a suicide hotline also are there because they want to be there, not because they have to be there. And if someone calls who's suicidal, typically those calls take longer. And the person on the other end of the line may be fretting that they're got a backlog of calls or patients that they need to see. Well, with a volunteer in a suicide hotline, they devote as much time as the caller needs to try to get the caller into a safe place emotionally as well as physically. So there are a lot of different things I learned in the course of directing a crisis center for many years, and actually in many ways being educated by the professional staff about the subject. So I tried to bring that background to my books as a way to share some of the things I've learned with people who, like me, don't have a clinical background per se, but have a strong interest and desire to learn more about the subject.
Yes, that's very good. I think actually sometimes having somebody who did not go through the grad school training can have a fresh perspective on it, especially that you were immersed in it. And the hotlines and the day-to-day versus a lot of clinicians, if you're in the outpatient world, they don't run into suicide every week. Even maybe they'll have a client who has some suicidal thoughts or ideas, but not moving to the point of plans. They're just sort of talking about it because they're depressed and feel like they don't like where their life is going. And being in that environment that you are in, you're getting a lot of data and information about what's helping people, what's not, what are the situations that are anecdotally causing this, what are, and then matching that up with some of the statistics. So I appreciate that background. I think, I was doing some research on this. There had been a number of crisis lines all across the United States, but it wasn't until about, I think, the early 2000s that they finally made the National Suicide Prevention Lifeline. The government and some people kind of put that together. And often what I was reading is that in the 1990s, when they were trying to make this line, be a cohesive line instead of just various crisis lines out there, there was a lot of pushback in Congress about, that doesn't happen to regular people. That's just sort of a niche issue or whatever. That's a medical issue. And the government really didn't see it as a public health issue at the time. And I think it's come a long way now that the suicide hotline, which is now called the 988, the kind of a national mental health crisis line, but it's mostly dealing with suicidal ideations and things like that. It is now getting more calls than ever every year. It just breaks records every year to help people de-escalate and find help or immediate crisis help. Any thoughts on that?
Sure. I mean, I served on the steering committee of the National Suicide Prevention Lifeline for a long period of time while I was director of the crisis center. So I would go back to New York or Washington, D.C. Multiple times a year and talk with other people who were clinicians primarily, but also other crisis center directors. And we would talk about, first of all, the challenges faced by a 24-hour suicide hotline in terms of financial funding, in terms of programmatic funding, in terms of technology challenges. And then we would also talk about the specific need for a 3-digit suicide prevention number analogous to 911, which is where the 988 number subsequently came from. And that was at the time a long-term dream of many of ours, and it finally came into existence just a few years ago. And I think given the impact of the number of calls that it's receiving, calls and texts primarily, the service has just been phenomenal in terms of its outreach. Although I'm still finding that many of the people I talk to have never heard of 988. And it's I know those of us who deal in the mental health world can't believe that there are people who don't know about 988. But I know when I've written my books and I've mentioned to my editors or I've mentioned to my agent or others about 988, they kind of shake their head and what's that, even though they're highly educated people, but it's just not something that they are attuned to. So the implementation of the Lifeline in 2005, and then the subsequent change of that Lifeline to the 988 Suicide and Crisis Lifeline in just 2 years ago has made a profound difference. And it's also led to a large amount of increased funding for mental health services in general, which has obviously been very positive in terms of being able to reach out to people and effectively see that they get the help and counseling and care and support they need.
Yes, I agree completely. It's a well-needed service, and I'm glad that they finally did combine the lines to make a centralized way to take the calls. Well, I think for the interest of the listener, getting into your book a little bit, you call it the proverbial question, or why do people want to kill themselves? Why? And why do they want to complete suicide? And all of the things with that. There's a lot to say here because, again, like you said, it's a nuanced, complex situation, often involving, this is my kind of take on it, and I'll see what you say, but like, I think, first of all, escalated nervous system or emotional situation. Oftentimes there is an interpersonal problem going on. Also, financial issues can cause this, a loss of some type, a large event in your life. And then also not seeming or not reaching out to a support system or not having a support system, not getting the care you need and feeling hopeless, and also then having means and a plan. Those are just kind of things in my mind. It's not like a list. I was just sort of going off my memory. What are your viewpoints on this sort of reasons why people would try to end their life prematurely?
Well, I think certainly there's a degree of depression, of hopelessness and despair that is paramount in someone's life. And it might be the loss of a loved one, as you say. It might be an economic issue, loss of a job. It might be gambling debts. It might be the end of a relationship, a divorce. But all of these things are really kind of considered precipitators rather than causes. I mean, certainly you've got substance abuse and mental disorders which play a part. But as a number of researchers, particularly I think as Thomas Joyner had pointed out, really there are two things going on. Someone has to have the intent, the desire to die, which can be the result of many issues, as we just mentioned. But the other thing beyond that is they also have to have the capacity to kill themselves, which isn't always easy. I mean, the self-preservation instinct in humans is strong, and we go about our lives really trying to make our life longer, not shorter typically, and surmounting the self-preservation instinct isn't easy. It's not, there's a sense that dying by suicide is cowardly, and in fact, in many respects, it requires a degree of fearlessness that is often not obvious to people on the outside. You need to be able to actually, if you got a gun, you need to be able to shoot it. If you're in a high place, you need to be able to jump. If you've got a rope, you need to be able to hang yourself. And while that might seem in the moment easy, it's not at all in many respects. And one of the real, I think, myths about fiction is that, and I think I just wrote about this in the Psychology Today blog, is that for the most part, particularly with adults, suicide is not an impulsive act. It's something that people have thought about maybe for a long period of time. They've been ideating about it, and only recently have they started to put a plan into action, but it's not something that just pops up. And despite several studies which apparently would seem to indicate that there's an impulsivity behind suicide, that really mostly applies to use. And And adults typically tend to think about their deaths, to plan it, to procure the means, to decide on a date, particularly a date that may have significance to them in terms of the death of a loved one, the end of a relationship, a birthday, whatever. And then they put that plan into place. So it's a combination of intent and capacity, and again, this speaks to the issue we talked about earlier about the complexity behind suicide, and there are lots of risk factors and warning signs that you can see if you're in a position to help somebody, but maybe as a family member you are afraid about the prospect that someone might be actually considering ending their life, or you're in denial about it. I know when I was appearing in classrooms regularly talking about youth suicides in particular, oftentimes kids would come up to me after the class was over and express some pretty dark thoughts and I would ask, have you talked about this with your parents? And they said no, because I don't want to scare my parents, and my parents wouldn't know how to respond to it. Well, who else do you talk to? And if they talk to anyone, they most likely only talk to a friend. And so if you confide in a friend, then that becomes a real burden for the friend to bear. The friend doesn't want to see an individual get hurt, but they also don't want to betray his or her confidences, and usually they're sworn into silence. So what do you do with that? It's one of the challenges that in the crisis center world we kind of refer to as the secret burden, and how to respond to that. And as a friend, you have to break confidences and tell a trusted adult, a teacher, a coach, a parent, whoever, knowing that if that friend is upset with you, that may be short term, but you're saving their life long term if they get the help they need. And there are so many different factors that go into a suicide attempt that you have to be really aware of things like, do they have access to lethal means? Do they have access to a firearm? Do they have access to highly addictive and essentially lethal drugs? Do they have access to a car or a jump site that could be turned into a tragic site? I mean, one of the things you do on a suicide hotline or as a suicide helper on a bridge or wherever you might be is after you've established rapport with the caller, really try to find out some of the specific things around them. First of all, have they ever attempted suicide before? Does their family have a history of suicide? Are they physically isolated? Have they lost interest in hobbies or sports or their personal appearance? Have they settled affairs by giving away prized possessions? You start learning all these factors, and they all go into ultimately what you call a suicide plan, where if you're dealing one-on-one with a person, whether as a clinician face-to-face or an individual over the phone or wherever, you really try to help them establish what resources they have and where they should go, and what they can do to help themselves. And if they're not willing to call 988, if they don't have a therapist, or if they have a therapist, but they're not willing to talk to that therapist about this person, and they're not willing to allow you to talk to the therapist, then you have to take steps to get some advice yourself, which could be through talking to another therapist or calling the Suicide and Crisis Lifeline. But the thing is that there are people who attempt suicide don't necessarily want to die. They want their pain to end. They want whether it's physical, or mental, or emotional pain, they want to be rid of it. And oftentimes their thinking is so constricted that suicide seems like the only option. And what you try to do is kind of widen their blinders and let them see that there are other options. And you don't try to take suicide off the table, because for some people, thinking about suicide is actually comforting. They know that if their life spins out of control and things get really bad, they can always end it. They can take control of their life in the only way they can, by choosing to kill themselves. So you don't take that option away from them, but what you try to do is put it farther down the list, so that it's not number 1, 2, or 3. Maybe it's number 7 or 8. And oftentimes in the suicide prevention world, buying time is everything. If you can just buy a few minutes, or if you can buy an hour, or if you can buy a day, you can make all the difference. And so that's really the first and foremost goal, is to buy time, and then secondly, to work on a plan, and then thirdly, to help the individual implement that plan.
Yeah, absolutely. And yeah, like you said, there's a lot of clinical wisdom there, because you don't want to make them feel bad for thinking it. You don't want to take it off the table. You don't want to tell them, don't do that. Like, it's got, for a lot of people, if they have lost control of their relationships, their finances, they feel like the world is against them. Their thinking constricts. That's actually a really good way of putting it. I almost call it myopic, where they can only see things through one lens. And that could be due to a number of stress factors and maybe traumatic situations they've been through. And thus it becomes what I call like the binary. I can't face it, so I've got to die. I have no control, but the only thing I can't control is my own death, right? And the difficult thing is that suicide is a permanent solution to a temporary problem. In life, most people go through horrible, traumatic things. They have positive moments, but there's also a lot of difficult things that will happen to you if you live long enough. So how do we help the person get a hold of their protective factors and increase the protective factors, such as family, friends, pets, connections, getting to a clinician, getting to a hospital? Again, like you said, they've lost interest in so many things that it's sometimes difficult to get the person going, especially with depression, because depression, there is a spectrum, but when you're deeply, deeply depressed, you can look it up in the DSM-5, but there's lots of factors that involve inability to see a future, inability to have any hope, of, like you said, a very narrow view of your life, and the effects, and having any hope at all. So I think we're starting to get into why, but it's also, like you said, it's nuances for each person, and there's a number of factors we know that can lead to people actually following through. And I do like that you already kind of covered some of the fact versus fiction about it being impulsive. And I would say anecdotally, as a clinician, having worked in clinics for 18 years of various types, the adults are definitely more methodical about planning. And that's why when we talk about it as clinicians, we say, thoughts. Okay, let's dig into that. Do you have any plans or intentions to do it like in the next week or two, or tomorrow? Because plans and intentions indicate possible lethality, where we might have to step in and break our HIPAA confidentiality, versus somebody who says, well, I'm always thinking about it, or I only think about it when I realize I have no money, but I'm not like actually going to buy something to do it. Right. So some of the facts versus fiction, I think, I don't want to go through all of them, but the idea, like you already kind of hit it, is that they want to die. That is not necessarily the case. I would even say in terms of clinical language, like you said, people want something to die. They want something like metaphorically. I can't keep doing this. I'm in an abusive situation. I can't keep going through this. This keeps happening to me. They want something in their life to end. And they can't see the option that it doesn't have to be their life that ends, but they don't see another solution. And that can become part of the perseverating to eventually make a plan to end one's life.
One of the things that you try to do as a counselor is to help people understand that just like good times don't last forever. Bad times don't last forever either. And again, It gets back to the whole idea of buying time. One of the things, though, that is important to understand is that that phrase, suicide is a permanent solution to a temporary problem, is one that I used a lot when I was starting out at the crisis center, and I soon learned was not always accurate, especially if you're dealing with older adults, because for them, they are experiencing a lot of permanent disabilities. I mean, they're physically, they may be declining. They may, hearing, eyes, mobility may be affected. They may have recently retired, no longer have income, no longer have all those job contacts. And so the reasons for their isolation and their potential depression can be much more than a temporary problem. It can be a permanent problem. And what you try to do then is to help them get out of it. If someone is feeling, let's say a senior, and feeling isolated, then you might work on strategies to get them out of the house more. Maybe they volunteer with a local organization. Maybe they adopt a dog. Maybe they go to the library. Somehow they just get involved. With teens, you're taught you end up talking a lot about the future, but with older adults, you talk a lot about the present because their futures are limited, and they really want to focus on the here and now. I mean, kids want to focus on the here and now too, but what you try to tell them is that what happens today can be totally different tomorrow. And the things you experience now, which seem so incredibly important 10 years down the road, are going to seem relatively inconsequential. And so you just, again, for everybody, try to put things in perspective without judging them. It's really important not to be judgmental in any way. And as humans, that's often difficult for us. And yet in the world of suicide prevention, it's really essential to be open, to be caring, to let people know that you are there for them without being critical or appearing judgmental. And that's especially hard the closer the person is to you, because we feel that we know that person well enough to be honest with them, and yet we can never know them well enough to be able to make to know everything about them, to know everything about their thinking. And so we really try to step back from that. I know one of the early challenges that when you operate a suicide hotline and dealing with some of the prospective volunteers who go through a really rigorous 6-week training program before they even start working on the lines, and then they work under the guidance of a mentor for a long time. But one of the really important things you do for them is to try to help them or try to figure out why they're volunteering. And there are some people who will volunteer because they want to save the world or tell everybody how to write their lives. And that's not the role of a counselor, at least in a suicide hotline setting. And I don't think it's necessarily the role of a clinician either. It's to set a path, but it's not to make decisions for the person. It's to allow that person to make the decisions on their own with as much information as you're able to give them. So there are a lot of things about suicide prevention that go beyond the specifics of risk factors and warning signs to really influence and direct a conversation with a suicidal person that ultimately gets to the point where they are able to be in a safe place. Suicide may not be off the table entirely, but it may be so far down that they're able to focus on other things first.
That makes complete sense. Yeah, and I appreciate your perspective about the elders. They might have a permanent problem, like losing somebody in their life or being completely isolated and all those things. So it's very important not to judge and not to put your values and your personal opinions onto somebody else. We are only supposed to be a guide. And the only time we actually probably supersede someone's willpower is if they say, I have a plan to do it tonight. And then we, of course, have to unfortunately work on involuntary hospitalization. But most of the time, people are just talking about it, and they need to be heard, and they need to be able to make meaning out of why they feel this way. and what led it to this way, and how maybe we could help them find a different path, but we're only the guide. We're not the person pointing our finger and telling them what to do. Some of the facts versus fiction that I thought was interesting was that it's important to remember that just because you hospitalize somebody or they go to the hospital doesn't mean that the danger is over, right? This idea of like, oh, they've been hospitalized. Okay, now they're okay. And they're going to get the treatment they need. And then they're going to walk out. Can you explain that? Why we need to really look at the long-term help of this person who might have had a suicidal attempt or thought?
Sure. Well, oftentimes when a person is hospitalized for a suicide attempt or strong ideation, there's a feeling among family members and friends, they breathe a sigh of relief saying, oh, good, the professionals are taking care of it. The person's going to be in the hospital on a 72-hour hold or 1 day week hold or whatever it might be. And they take care of it once the person is released. I won't have to worry anymore. And in fact, as numerous studies show, which I cite in the book, the risk is substantially elevated in the week or two after someone is released from a hospital setting. And a lot of that has to do with that a misperception that when a suicidal person demonstrates kind of an elevated mood swing, it's easy for people around them to say, "Oh, they're getting better. They're past that. We don't have to worry about them anymore." And in fact, it's just the opposite. They're experiencing an elevated mood swing because they've made a decision. They've taken control of their lives. They're going to end it, and they don't have to worry anymore. And that's something where knowing that. You need to be aware that just because someone has been released from a hospital following a suicide attempt, that's when it's really critical that they get immediate long-term care from a licensed therapist, because without it, they could quickly decline and be attempting again and possibly completing it this time.
Absolutely. And I would say, I guess I'll be candid here. I've had a relative that did commit suicide, completed suicide is the correct term. And we had worked, they did not want treatment. And because of some of their behaviors, they did get involuntarily hospitalized for about 4 weeks and were doing quite well. Uh-huh. But they became very elated and excited when they were getting out. And they refused any sort of service when they left, which they're an adult and that was their choice. And they were able to complete within a month and a half of that time. And I actually was very worried when they got out, because I was like, they're refusing all of these programs, all the therapy, all of that. And I had a bad feeling, and I knew that. And then I talked to them and I thought they're disconnecting from life. You could sense it, but there was nothing I could do because they knew the game. They had been hospitalized about 7 to 10 times, and they knew if they told anybody anything in their life that eventually they'd have to be hospitalized, and with their behavior as well. So I do think that in every situation there is hope. I definitely think that person's factors, I won't get into it, but they had a multitudinous number of factors, including health, financial, trauma, lack of support, housing issues, etc. And because of their illness, they also refused help. And they had a history of their grandmother committed or completed suicide. Sorry, I grew up in the 80s. So everybody said committed back then.
I understand.
Yeah. And so, there's a lot of risk factors that go into this, but I think it's something that we can't avoid as a culture or as people. And I also, on the positive side, have been involved with family members and people that wanted to die and got close to it, and we were able to get them help, and they're doing great now and have no intentions of hurting themselves, including clients who were on the edge when they came in and saw me for the first time. So there's been a lot of success stories, most of them success. But if you've been in the field or you've been alive for this long, you unfortunately know of some negative ones. And everything you said in this book lines up with my experience, both on the positive of getting people surrounded with natural positive supports and getting them back out of the crisis, de-escalated to a point where they can function again, and then their life gets better. But also on the other end of seeing how sometimes these things go wrong. One of the things you talked about in here, and I can't remember where it was, but about how people that are planning it out as adults will oftentimes kind of like rehearse it. They'll put the gun in their mouth, they'll put the noose around their neck, they'll take a certain amount of pills, but not too many pills, to kind of get themselves, because it's a very scary, your nervous system wants to keep you alive. So it's a very scary thing to override that. And I think I want to talk about that story without using the person's name because, or their relationship to me, just for the confidentiality of the relatives. But I think it's important that this affects so many people. And you were talking about in the numbers section, the amount of people, 48,000 a year in the US that we know about. This is not only affecting that person, but it's affecting everybody that knew them. Exactly. It's affecting any sort of job they had or position in the community. It's affecting any sort of children they had or relatives they had. And this is causing a massive systemic crisis where, let's say, each person was connected to 15 or 20 people, perhaps. Sometimes they're only connected to a couple people if they're in a situation where they're isolated. This is having a massive effect on the culture. Any thoughts about that?
Well, yes, that's exactly why I think it's important for everyone to understand that suicide is much more than a mental health problem. It's a public health problem with really wide social consequences. And ultimately, it ends up impacting every segment of the population, every segment by age, by gender, by race, by religious aspect. I mean, basically, no one is immune from suicide. If you don't attempt it yourself, you probably know someone very close to you who has attempted it. And so one of the things I talk about closer towards the end about ending suicide is that because of the stigma around suicide, it's really important for society at large and individuals in particular to help bring suicide out of the shadows. To shine a spotlight on it. We can't really deal with the problem until we know it. And so it means that when you have a suicide of someone in your life, it's very easy to try to cover it up, to pretend that if it was really they had a particular illness or accidental death, and not disclose to the public the true reason why, or the true method why someone died. And it's really important for us to bring suicide to the forefront if we want people to be able to deal with it effectively. You talk about your loved one. I mean, one of the things that I talked about in my book about the final leap about Golden Gate Bridge suicides was that the Golden Gate Bridge opened in 1937, and for years, 3 months after it opened, there was the first suicide, and for years after, there were continued suicides. And the mental health community, all sorts of doctors, psychiatrists, clinicians, came forward and presented all sorts of empirical evidence why the bridge needed a suicide barrier. And basically all those well-articulated arguments fell on deaf ears. And it was only when the surviving family members became vocal advocates for a suicide barrier that the whole tenor of the conversation changed. I mean, they had the willingness to share their grief publicly in order to get people to understand the impact it was having on them and their extended family. And that just, as I said, changed the whole conversation and enabled, for the first time, really a commitment to end the problem. And at the Golden Gate Bridge, and I feel that same kind of commitment can be ended elsewhere, or can end the problem elsewhere. But the first thing we need to do is talk about it. And unfortunately, suicide, like certain other topics, incest, discrimination, and the like, is something that we often try to hide. But we really, if we want it to go away, if we want it to be minimized in terms of its impact, then we really need to be at the forefront in talking about it.
I agree. Yeah, I think you were talking about sometimes, a lot of times in the obituaries or somebody dies, they don't mention the cause of death. People don't want to talk about it. We want to cover it up. And that,
They
I think,
died suddenly, but with
suddenly, right. Suddenly at 30.
No explanation.
Right, exactly. So I think it's important. This book is important for not only your average person to know about it, but I think education systems need to have this book. And if politicians read anything, they should read this or have their aides read this to kind of understand some of the things we can do. So I wanted to talk about some of the ideas that you have that are like societal, because obviously mental health, hospitals, clinicians, family members, people, there's lots of tips to try to help people here, and getting connected, talking about it. There used to be a myth that if you talk about it, that people are more likely to do it. And in fact, I don't know if you said this in the stats in your book, but if you talk to people about it, they're actually less likely to do it versus not talking to anybody. That's correct, right?
Yes. Well, and this is something that I learned from a woman who was the executive director of San Francisco Suicide Prevention. I would go into classrooms and talk about suicide prevention, but not in a classroom, into adult settings, service clubs and like, and talk about teen suicide. And I would present all sorts of stats that were evidence of the extent of the problem. And I knew that my talk was basically falling on deaf ears. And so I adopted the attitude of Eve Meyer at San Francisco Suicide Prevention. And what I did was, when someone would raise that issue that, well, talking about suicide is going to plant the idea in someone's mind when it wasn't there before. First of all, we talk about don't smoke, don't take drugs, other issues, and we don't think that those plant the idea in someone's mind. But what I would do when someone would mention that, I would turn to them and I would say, "Are you thinking about suicide?" And the woman or person would say, "Definitely not," almost horrified that I would even suggest it. And I would kind of nod and say, "Fine." I'd go on and talk a few minutes more, and then I'd come back to her and I'd say, "Are you thinking about suicide now?" And she'd be even more reactive in her response. And it was kind of a way to effectively get the point across that talking about suicide does not instill a thought in someone. They've almost always been thinking about it well before the subject comes up, because they've given subtle hints of it. And what you're doing by talking about it is giving them permission to share their thoughts and do it in a way that they feel you're going to listen without judging.
Yes, exactly right. You're giving them access to open up and tell the story, because oftentimes there's a shame factor. You don't want people to judge you. You don't want people to freak out and bother you about it. This is your personal information. So, opening it up, and that's very important. What are some of the ways, just in brief? Obviously, you have statistics and well-researched things people can do. We've kind of talked a lot about what people can do personally, but what about schools and businesses and the government and the military? What are some of your favorites that you wanted to share? Because you actually have something for almost every segment of society that I can
I certainly
find in here.
First, before I get into those others, I'd like to kind of go back to individuals for just a second, because it's much more than just talking about it. One thing I'd like to suggest is that people can be motivated to be trained in suicide prevention. There are a number of excellent training programs out there, and that many people have taken a class in CPR. And the fact is, the odds of seeing someone have a heart attack or stroke are much smaller than the odds of knowing someone who is having suicidal thoughts. And that's not to minimize in any way the value of knowing first aid, but it's rather to emphasize the importance of skill building when it comes to suicide prevention. So I think becoming trained can be really important. If someone's really motivated, they can volunteer to work on a suicide hotline, or they can learn about hotspots in their area that may have a jump site or otherwise be a danger spot for suicide. And the last thing I really want to mention to people is that because guns are so prevalent in our society, parents really need to get in the habit when their children ask to play at a friend's house to ask the parents of that friend whether they have a gun in the house.
Mm-hmm.
Because the stats show that a gun in the house, there's 5 times more likely to be a suicide than there is in a house without a gun. And that gun owners, in turn, shouldn't feel offended by the question, but to use it as an opportunity to demonstrate responsible gun ownership, the fact that they lock their weapons and that they store their ammunition separately, et cetera. So those are a few other things that individuals can do. And in terms of, say, schools, you can develop plans for how to deal with the suicide of a student or teacher or staff member. Oftentimes schools have very detailed plans in place for how to deal with bullying, but they don't have any plans in place for how to deal with the suicide. When do you call in the police? When do you call in grief counselors? How do you handle a memorial service? You want to be respectful of the individual who died, but you also don't want to inadvertently glorify the death in a way that leads students or others to sit in the audience and say, "I wonder what people will think about me if I died tomorrow." So schools can really work on plans which will really increase the capacity of staff overall to assist any individuals, students, or colleagues that they feel are potentially suicidal. Physicians can cut back on prescriptions for highly addictive painkillers. And related to that, drug companies can package their own over-the-counter medications in small amounts with what are called blister tabs, which are little tabs that you have to depress the tab with your thumb to dispense one tab. And so if you want to dispense a number of tabs in order to overdose, you've got to do that many times, and it causes blisters and becomes an inconvenience. And there are a lot of examples in England. They changed the whole way antiseptics, certain kinds of medications were packaged so that you couldn't go into a place and order a 500-pound capsule of Tylenol. Much smaller containers, and that really reduced the suicide rate. Clergy are thought to be mental health counselors because of their just their training and the fact that they're really taught to be compassionate and caring for people. And so oftentimes they're in that role without the needed skills, and they can make sure that they keep lists of therapists available to them. So if a member of their congregation expresses suicidal thoughts, or a family member, they have a place to refer to them. They can even donate an office in their church building for a outside therapist to come in once a month to provide counseling to individual congregation members if so desired. So that's an idea. And, architects, for example, can advocate that, and I think this is going on in New York, where they can advocate that the Uniform Building Code includes suicide prevention as part of its conditions for construction, which would go a long way towards making sure that future building projects incorporate suicide prevention as part of the structure. Gun shops can post 988, the crisis line number again. They can ask people who are buying a gun what they plan to use it for. They can suggest that gun owners get training and encourage them to store the gun safely. On a federal level, you can have universal background checks for guns. And if they're mandated, you can have red flag laws. Regarding jump sites, there's legislation that exists in the transportation world where if a certain number of accidents with fatalities occur at a dangerous crosswalk or intersection, that some sort of stop sign or stoplights have to be installed. You can use that same thinking to say that after a certain threshold is reached in terms of suicides from a potential bridge or hotel or whatever, that a physical suicide barrier has to be erected.
Such as a net or a fence.
A net or offense, yes, something physical, not a sign, because that's usually the first thing that people want. They want to put up a sign, they want to put up a phone to call, which studies showed are very ineffective.
Right. If somebody's already going up there, they're probably not going to make the call at that point.
Yeah. I mean, we don't expect a sign on a steep mountain road to stop people from driving off the edge if they're intoxicated or not paying attention,
Right.
which is why we have fences on guardrails on mountain roads and fences around swimming pools. In my one book, I talk a lot about what the military can do. The biggest challenge, I think, is just changing the culture in the military, where it's not a weakness but a strength to ask for help. And that as much training as service members receive in preparing for battle, they need to receive that much and more in helping them reintegrate into society afterwards. And in the mental health world, the zero suicide model has been adopted by a number of national entities and based on a behavioral healthcare system in Detroit that really started everything in the year 2000. And it's really looking at everybody who is admitted into the hospital system and assessing them for suicide, whether they came in for a suicidal reason or not at all, if they've got the flu, if they've got a broken arm, whatever the reason, they're also assessed for suicide. And just that practice of asking the question goes a long way. And then once they ask the question, of course, then you need protocols for how staff handle the answer. But all of that is readily available. And the whole idea behind the zero suicide model, which has been adopted by lots of the major healthcare providers in the country, is to say that it is possible to reach a zero suicide population. And this is the way to do it. But the point of my book is that achieving zero suicides is not just the responsibility of the healthcare system, it's the responsibility of everybody. And that's why I try to make all these suggestions for what other facets of society can do to alleviate and hopefully end the problem.
Absolutely. And I love how common sense some of these things are, right? I mean, there's requirements from OSHA to put up a wet floor sign so people don't fall and break their neck. But yet we know of certain bridges in certain places with high suicide rates, and yet why don't we have that built into the code of building, right? Yeah. And I know that some hotels have started doing certain floors, the windows are locked and only have certain types of vents or ways that they open. A lot of bridges in where I've been living in cities I've lived in have like these massive sort of fences that go all the way up and over to the other side, so you can't really get off the bridge in that way. And just like, for instance, I mean, this is a big one. There was a suicide I was friends with. This is actually kind of a famous one. There were two musicians in Arizona in about 2012, Amy and Derek, and there's a documentary about them, Nowhere Man and a Whiskey Girl, if you look that up. And Amy was sick with lupus, and actually her daughter, who she had to give up for adoption when she was young, her daughter won some sort of like Singing with the Stars or one of those things. She was adopted. Anyway, but Amy and Derek, I knew them from the music scene in Phoenix, and I did not know any of this information until they died because I didn't know them that well. I'd only seen them at music shows. And Amy was in the, I believe, University of Arizona Tucson Hospital because she had to have some sort of operation due to complications with lupus. And her husband, Derek, and I was up in Phoenix, and her husband, Derek, was worried, and he had talked to friends like, well, she could die from this operation. And like, what are you going to do? And he kind of was like, well, I'll be here for you or whatever. Well, she did die in the operation. I think they were in their probably early 40s at the time. I was probably 10 years younger. And the next thing I knew, I didn't even know she had died, but within 24 hours, he had gone to Walmart, purchased a handgun, and shot himself in the head and died. And his landlord, oddly enough, was Doug Stanhope, who's a stand-up comedian, quite controversial man, but he was very good friends with both of them, and he was just devastated and talked about it with a lot of people. And I just went to a tribute to them when was that? In the spring. There was a tribute concert to them in Phoenix. But I remember that day because I found out she died, and I was like, oh, this is horrible. And they're like, yeah, and he died too. And I was like, what? He wasn't in surgery. And they said, this is what happened. And I thought, my God, why don't they have a waiting period? If you see some guy walking in at 10 p.m. to Walmart and buys a gun and a pack of ammo, looking horrible, which is exactly what it was. His landlord, Doug, he knew exactly, like he traced his steps. He found the receipts and everything to give to the police, and because he owned the house. And this is an example of, and they had, hey, I'll meet you tomorrow. We'll get breakfast. They had already made, he had actually made plans to have breakfast with, to be able to help him with his grief. But I guess no one thought to go over there and stay the night with him. I don't know exactly what all went down. I know as much as I know, but he went and purchased the gun and killed himself that night. And I thought, my God, that's a perfect example because his wife died, and that was horribly tragic and obviously horrible, but now he's dead too, right? Because of the loss. And he, he was not a dummy. He knew how to get help. He had plenty of people that cared about him, but he, at that moment didn't make that call. And I thought to myself, if he had not been allowed, if he had had to wait 5 or 10 days to buy that gun, he would have had breakfast the next day with people that cared about him, and maybe they would have talked him down, and that wouldn't have happened. And so you do write about that in your book, because I think, in what instance does somebody immediately need access to a gun? Because if you're being attacked by a criminal, or your house is being broken into, you're not going to just drive to the store and buy a gun. If I want a gun for protection, I can buy one. What is it going to harm me to wait 5 or 10 days for a background check or something like that? Or if I need to go hunting, I can plan ahead and go buy one and wait 5 or 10 days. But who's buying a gun that needs immediate use? That's my question there. So what are any thoughts on that?
Well, I think, one of the things is that, the whole conversations we have these days around gun reform are typically focused on assault weapons. And because we're really outraged and by all of these tragic mass shootings, and we want to really limit the access of guns to people with that kind of hatred and that kind of potential illness. But we don't really think about the impact of guns on suicides. As you mentioned earlier, more than half the people who die by suicide use a firearm. And yet only 5% of suicide attempts in this country are with a firearm. The vast majority, over 70%, are an overdose with pills. Right. So being able to look at common sense gun reform in terms of universal background checks and red flag laws, which the majority of gun owners really support, because they want to see that their firearms are used responsibly by other people, just the same way we have highway laws that make it possible and necessary for people to drive safely on the roads for the most part. We need the same kind of thinking around gun reform, and the real challenge, of course, with guns is that the people who are gun owners really accept it as an inherent right and don't want their guns taken away from them. And as I noted in the book, there's all sorts of things we can do around gun reform, and I'm very careful not to call it gun restriction or gun reducing access, is just look at the ways that universal background checks and red flag laws, just as 2 examples, don't have any impact at all on the people who are current gun owners. They can still go out and buy more guns if they want. They can still use their guns for hunting, target practice, whatever. and their rights aren't restricted in any way, but we've just made guns safer in some respects for suicide. And that's the way I think we have to look at this. And I mentioned in the book, there's a gun shop in New Hampshire that within the course of just a few weeks, 3 people came in, I think it was 3 people came into the shop and bought firearms, and subsequently within a day or two killed themselves. And that led to this whole movement in New Hampshire around restricting or at least re-examining the way firearms are sold and getting gun owners to start talking to people prior to selling them a gun. And that the goal is not to sell people a gun so that they can kill themselves. The goal is to make sure that they're going to use that gun in a safe way. And you want them to be properly trained. You want them to be properly checked, and you want them to be able to use that gun with confidence without using it as a means of suicide.
Yes, absolutely. I mean, I feel like, we're getting into the gun debate is so difficult because I feel like people think that they're being logical by wanting nothing to change about it. But in fact, I feel like they're being overly emotional.
And that's probably why the guns and suicide chapter in my book is probably the longest chapter of the book, because there's so much history that goes into it.
There's a lot of history, a lot of cultural nuance, and a lot of assumptions, unfortunately, made by folks.
And the fact that the NRA has been such a powerful lobby. I mean, to talk about the fact that for years, the NRA really prevented Congress from approving funding for CDC studies around firearms. Just because they've basically got the CDC heads to say, or to cut the funding for CDC for gun studies from, I think, down to up by 96%, just because they didn't want anything that restricted access to guns. And even though the smart guns have been developed that require fingerprints or face recognition or some electronic means of recognizing the user, so that another family member, for instance, can't just pick up a gun and use it. NRA has been opposed to that as well, because they don't want to see any restriction on that limits access to guns. So I think people just need to use a lot more common sense when it comes to gun reform. Recognize that we're not going to change the culture of gun ownership in this country, but there's a lot we can do to make firearms and suicide less connected.
Absolutely. I think there's a lot to be done. And in fact, in the book, I think your solutions are quite utilitarian and practical and don't trot on anybody's rights, I think. And the interesting part I'd like to point out is there are many things that have less lethality in the United States that we are working on preventing than the amount of suicides per year, and yet they get more attention, I think, because there's a cultural blindness to suicide, and we don't want to believe that this is a common thing that can happen to people in certain situations. And it's not a simple answer; it's a nuanced answer, like you said. And there's many different ways to help prevent it. While we can't prevent depression, we can treat depression, right? While for suicide, the best thing is prevention. You can't, unless somebody survives, you're not treating suicide. You're trying to prevent them to getting in that position so they can get the treatment. Versus when you get to the edge and you have the means, that's when things end up to be a tragedy. So I think I really love that you wrote this book and you broadly and simply laid it out. Like I said, I am a distractible reader. I have 7 books sitting on my nightstand at a given time and 5 audiobooks going in my phone. So the fact that I was able to get through half of this or more in like a couple of days and skimming the rest of it, I mean, I think this is a book people need to buy, especially anybody who's been impacted by this, because I think there's a lot of people out there who are retired who actually could make a big difference by going to city hall meetings, school board meetings, police meetings, different things like that for the community with these facts. And it shouldn't be controversial. I just think it sounds like, again, it's one of those things our society doesn't really want to look at. We want to make it someone else's problem, or just make it completely personal. Like, oh, we can't control people. Well, no, we can't control people. But why do we have lines on the highway to drive on the right and the left? Why do we say in most states you can't be on your phone while driving unless you use a Bluetooth connection? You can't be on your screen. Why do we have a license to drive a car? Why don't we just let anyone drive a car if we can't prevent accidents? We know statistically that these things can lower the incidence. So I think I appreciate I'm a huge fan of utilitarian solutions that don't restrict freedom, but increase safety and education. And I think all of your solutions only increase the ability for people to live with less suicides in our lives. So thank you for that.
Well, thank you for the words of kindness. Appreciate it.
Yes. Is there anything out there? Okay, so we covered a lot. We're kind of wrapping up here towards the end. Is there anything out there you want to say to the public or to potential readers of the book that you haven't been able to say yet?
I think we've really covered just about everything. I mean, again, I would go back to the three things that I hope readers get out of it in the very beginning, and that suicide's much more than a mental health problem. It's a public health problem with social consequences. That restricting access is one of the most proven ways to prevent suicide, and that ending suicide is possible if people become committed to it. And I think that the book hopefully provides a blueprint for reaching a zero suicide future. And I think we also have, we haven't really touched on it, but there are a number of examples in the book about steps that other countries have taken when there's been a mass shooting, and how that's impacted future gun legislation. And the one I'll just mention, because it's to me really paramount, is that in Israel, it's obviously military suicide is mandated, and in Israel they found that
military service is mandated.
Military service. Yes, sorry,
okay.
Sorry, I appreciate the correction.
No worries.
That young men 20 to 24, which is the age for the military service, had a very high suicide rate in Israel. Mm-hmm. And so they made a simple change. They made it, they stopped allowing Israeli soldiers to take their weapons home with them on weekends. And that simple change dropped the suicide rate 40% in Israel. And it has stayed there ever since.
Wow.
Yeah, I mean, it's just, very simple change. You can't take your weapon home on the weekends. That's it.
Accessibility, because then the means, if you're so depressed on the weekends, you don't have the means to do something in about, that something you can do in about 5 seconds. You have to wait to get back to work. You get back to work or whatever the service, and you're around all your friends or coworkers again. And then yeah, exactly. This is human behavior. I mean, it's really hard to explain to people that haven't been in the field or clinicians that while humans want to be logical or pretend we're logical creatures, we're quite emotional, and we actually make up a lot of stories about why we do things. And we have a lot of behavioral characteristics that are very similar to other mammals. The only issue, of course, is our brains are a bit larger, and we like to contemplate our existence and the reasons and balance these things in ways that are that can be lethal to us. So I love that example of just, you can't take your gun home on weekends. Okay, 40% dip. I mean, that's a massive statistical.
That's a massive change. I mean, Britain had the same kind of thing. Up until around 1960, the most common way for people to kill themselves was to stick their head in the oven and turn on the gas, and they asphyxiated to death. And then with the discovery of oil deposits in the North Sea, they've started phasing out gas stoves and ovens and replacing them with electric and gas oriented ones. And the suicide rate in Britain dropped 25 to 30% overnight with that change and has never gone back up. So again, a simple societal change has had a profound impact on the suicide rate going forward. And it's not like people cook less or anything else. They just don't have that method of killing themselves available anymore.
Absolutely. I like how you've gotten into the statistics and the policies in a way that I think is well needed. It looks, this book, where can people get this book right now?
So it's available on Amazon. You can also order it directly from the publisher, Johns Hopkins University Press, their website. Either place. And then I think a number of bookstores, probably in your area, if they don't have it in stock, they can certainly order it.
Right.
But it is available as a ebook as well as an electronic book, or as well as a hardback.
Important point I forgot to say is the subtitle, Suicide, Understanding and Ending a National Tragedy by John Bateson. So I think that is an even easier way to find it if you put in some of the subtitles on Amazon. I'm sure you can request, if it's from Johns Hopkins Press, you could probably also request it from your local library as well.
Yep.
So
yeah, I should have mentioned the libraries, definitely.
Absolutely. Yeah, I love it when you get into the libraries and then it kind of proliferates from there. So thank you so much for your time. And I would encourage all the listeners out there to pick up this book. I think it's well worth the read, and it's a way you can make a difference by getting involved in one of these segments of reform that's needed.
Thank you, Paul. Appreciate it.
Absolutely. Talk to you soon.
And there you have it. This has been another episode of the Intentional Clinician podcast. If you are enjoying the show, please leave us a rating on iTunes or share the show with people you know. I would surely appreciate it. As some of you know, I am passionate about preventing future violence in the United States. I have started a nonprofit with colleagues called the National Violence Prevention Hotline, which is a 501c3 organization. We are endeavoring to gain funding and collaborators and volunteers so that we can start a 24/7 hotline and chat line to reach potential perpetrators before they may act violently. It is a bold effort to curb violence and save innocent lives by working to connect with potential offenders while they are in the planning stages of violence, help to de-escalate them, and provide resources so that they can get appropriate professional help. The National Violence Prevention Hotline is looking to open up a conversation about violence in society, the causes, and the solutions. You can learn more by visiting our website at violencepreventionhotline.org. You can get involved by writing your congressperson from our website, sharing it with your network, or even donating to the cause. If you are looking for an EMDR International Association consultant, I am a consultant and I can help provide 20 hours that you need to become EMDRIA certified. Just check out the show notes and send me a message and see if we're a good fit to work together. If you are in need of counseling, do not hesitate to make an appointment with a local counselor in your area. You can also make an appointment with the excellent clinicians at Health for Life Counseling in Grand Rapids as part of the Trauma Informed Counseling Center of Grand Rapids by visiting www.healthforlifegr.com. And if you are in the state of Michigan, you can also schedule a telehealth appointment. The recording you just listened to consists of the personal opinions of Paul Krauss and his guest, and while these are based upon the literature they have read and the experience in their respective fields, the information on this podcast should not be viewed or thought of as the definitive opinion on any subject. Listening to this podcast is not a substitute for treatment. If you're in a crisis, please call 911 or the National Crisis Line at 988. Support your local bookstore by shopping at bookshop.org. That's www.bookshop.org. It donates a percentage of sales to local bookstores all across the United States, which I think gives character to our cities and a place to hang out and a place to explore. You can order from the comfort of your own home online while supporting businesses near you. If you are a therapist and you are not involved in your local counseling or therapist or social work organization, please get involved to at least pay dues so that we can have lobbyists help keep mental health care accessible at the government level, and also expanding into schools and other places that need it. And also, if you didn't know, counseling organizations and professional organizations are working to keep us from becoming gig workers for a lot of large corporations who are coming in and trying to buy up local counseling agencies or basically pay you what they pay for people to deliver food to your house. So, get involved. Until next time on The Intentional Clinician, I wish you all a safe and peaceful week.